Good day. You've joined the 5-minute goals of care discussion for patients with serious illness. So, the other day, I heard my colleague across the room in the ED say, and she was yelling, "Do you want us to restart the heart with CPR? And do you want us to help his breathing with a breathing tube if he stops breathing?" We've all heard our colleagues say things like that, but I cringed. We don't like having these discussions at all. So there's got to be a better way to do this. Hi, everyone. I'm Rita Manfredi from the George Washington University School of Medicine. I practice emergency medicine and palliative medicine. So here's Rover here, taking a look at the resuscitation sandwich. It's a special we have in the emergency department. The top layer is CPR, the filling is intubation, and the bottom is, well, I shouldn't joke about this, but this is so close to reality. Every single day, we ask people if they want CPR intubation without finding out about what they value in life or what goals they have or what's important to them. We always skip this step. Well, I won't skip this step. I have no disclosures. And what I do have are some objectives for you. We're going to look at some of the key barriers and facilitation to these kinds of discussions in the ED. We're also going to discuss key phrases because guess what? Words do matter. And I'm going to help you formulate a strategy during these high stakes emergency department encounters so you can sort of have a roadmap or a plan to go forward with this. So, first question, who needs a goals of care conversation? Well, let me ask you a question. What kind of patients do you see in the emergency department? You see patients with serious illness, end-stage renal, end-stage cardiac, end-stage COPD, all the time. That's our bread and butter. And you also see progressive illness and functional decline. What are those patients? What do we really call them? We call them failure to thrive. Traumas can bring in devastating neurologic injury, and you may get those patients who are, end stage cancer, or they've run out of treatment and they may be at the hospice stage. And we have seen all of these last kinds of patients. Those are the patients where you wouldn't be surprised if they died in the next 6 months. So you ask me, Rita, why do I have to do this? Well, COVID has been the great uncoverer, the great revealer, and COVID has uncovered the need to have these discussions. We see our healthcare system is so broken. Our poor primary care colleagues don't even have time in their clinics to talk to their own patients about their goals and what's important to them. So patients are in crisis. They come to the emergency department and we have to have these discussions. But you know what? We have the absolute opportunity to help a patient and family maybe make some of the most important decisions of their lives. Oh, Rita, it's too hard to do in the emergency department. I have one word for you, not. You're going to say first, hey, I've never been trained. I don't know what to say. Second, you say, hey, we're too busy. Third, there's not enough time, right? Well, I take disagreement with that. Surveys show that patients really want to die at home. Many patients die in the hospital. I think you're all aware of that. Clinicians used to initiate these conversations previously in the past, but now 80% of them think about having these conversations, but really only 20% have them. Remember, the best time to talk about how you want to die is when you are well, isn't it? And we in the emergency department set the stage for the patient's trajectory in the hospital. What we do in the emergency department determines how the patient does upstairs and where they go. If we put in a central line, intubate them, and send them to the ICU, they may be there for another 10, 14 days and be looking at a peg in a trach by what we did reflexively. So I'm here to tell you, we want to plant the seed and start the goals of conversation in the ED. So what is a goals of care conversation? It's brief and focused. I know that much. I work in the ED, and it's got to be brief and focused. Otherwise, I won't have time to do it. But I bet you didn't know that it's a procedure, just like a chest tube or an A-line. Now, would you do a chest tube or an A-line, just walk in there and say, hey, I'm going to go put in an A-line. I haven't done it before, but I'm going to try it on this patient? No, you train for this. You read the information. You have a checklist. You go to the sim lab. You learn how to do those procedures. And what have we done with goals of care conversations? Well, we've just thrown you to the winds. Go ahead in there, go tell the patient, get their goals of care, come on back and tell me. We're doing it all wrong. So I'm here to sort of help change the culture. That procedure is billable. It's a codable, billable procedure, goals of care are. And just like you would never think of not writing a note for a chest tube or an A-line, you should always write the note delineating how the goals of care conversation went. What do you include in it? Well, it pretty much makes sense. You've got to name the patient's goals. What's important to that person? And whether there's limits to care. Are the goals even achievable? And then recommend a medical plan to match their goals and what's important to them. Also, find out who the healthcare proxy is. So, how do we do this? What's the emergency department method for goals of care? Well, there are like 6 steps, and I'm going to share those with you. You want to, they come to us, and patients in the ED, they're in crisis. So we need to reframe their situation and say, hey, you're here. You're here because things have changed since last week when you were at home. And then we work them up. We give them a headline about what's going on. And a headline has meaning in it. We tell them the news, but we also tell them what it means. And then guess what? When you give somebody bad news, what are they going to do? Well, they're going to become emotional. So we've got to expect that emotion. And then we've got to respond empathetically. After that, we've got to determine what's important to them. And then we restate those important things back to the family. And it's only then that we can talk about recommending a plan. So let's go through these one by one, just to give you a good idea of how it works. So the clinical situation has changed when the patient comes to the ED. So it's important to assess what the patient and the family know, and then move on to, Mrs. Jones, we're in a different place now. Things have changed since you went to your doctor last week. You want to normalize that process. This is a discussion we have with all patients with serious illness. And then you might say, Mrs. Jones, would it be okay if I tell you what we found out today? So then you're going to deliver the news after you've done the workup. You've gone in, you've seen the patient, you've examined them, you put in the orders, you've gotten results back, and that's when you go back to give the headline. Tell them the news and give a headline, just like in a newspaper. The headline is information plus the meaning. Mr. Jones, your CAT scan shows an increase in your cancer, which means that the chemotherapy is not working. Or, Ms. Smith, your mother has an overwhelming infection called sepsis, and I'm worried she might not recover. Or, Mr. White, your dad is critically ill, and I worry he won't ever get out of the ICU. I wish I had different news. I'm worried she might not recover. So you give that news, and after that news, what do you expect to have happen? Well, they're going to get emotional. So you need to stop talking. People are incredulous, they're sad, they're angry, they're frustrated, they're yelling. But I know one thing, Emergency physicians are uncomfortable with strong emotions. So we try to avoid upsetting people by flooding them with information. Detail after detail we give, we get into the weeds with the information. We have a laundry list that goes on and on and on, and we think if we keep talking, they won't get upset. Very untrue. So you've got to stop after the news. Remember, if you skillfully deliver the news, the patient will become emotional, and that is normal. I'll always remember how the emergency physician delivered the news to me about my mother being very, very sick in emergency department 300 miles north of here. And he knew I was an emergency physician. And he called me on the phone. He said, this is the news he gave to me. He said, your mother is moribund. That's what he said to me on the phone. This is like 15 years ago. And I just wonder to this day if that's one of the reasons why I partially did my palliative fellowship, because of how that affected me. So I was really angry. I was very emotional. So he didn't respond to my emotion at all. Not one bit. Emotion happens faster than rational thinking. This is because of the lizard part of our brain. And we as clinicians don't know how to handle this emotion. Not at all. Studies show that if you don't respond to the emotion and have the temperature of the emotion come down, then families can't move forward. So we've got to articulate this empathy. We have to guide our patients and our families through this emotionally high temperature till they begin to move forward. So people may say, you give them bad news. Are you sure, doctor? Aren't there more tests we can do? Well, do you really think that's a cognitive question? Are they really asking me, am I sure? Well, sure, I'm sure. I just looked at the CT. I know what's going on. No, they're not asking a cognitive question. They're emoting. It's not cognitive, it's emotional. So you've got to respond to that emotion. Oh, I can see how overwhelming this is. Mrs. Smith, I can't imagine how difficult it is to hear this news. Or Bob, Roberta, your father is so lucky. You're such a wonderful daughter. And always support. We're going to help you through this. And if you can't remember what to say, just tell me more. Use statements like these until the emotional temperature comes down. Okay? And remember, you want to determine the patient's values. You want to find out what's important. And you know that you're ready to move forward when that emotional temperature comes down. And this part of the procedure feels the most artificial to most emergency physicians. The key point, and so because it feels uncomfortable, I actually tell the patient what I'm doing. We may have to make some important decisions about your mom's healthcare in the future. And I'm going to be able to help you with that if I know what she's hoping for and what's important to your mom. Given this situation, what is most important to her? By determining what the patient values, what's important to the patient, what makes the patient get up out of bed every morning, you can then recommend the best treatment. We have some decisions. So it's important for me to know what you're hoping for. What is really important to you? So maybe Mr. Jones says to you, the most important thing for me is to get home and to be there with my family on Christmas and Thanksgiving. That's what's most important to me. Or grandpa may say, hey, I don't really want to live. If I can't go out in the backyard to my butterfly garden, forget it. Put me away. Other people may say, I really want to go to my daughter's graduate. I want to see my son get married. Sometimes family members just haven't talked about this. So what do? Well, a technique you can use is If the dad is in the bed talking to the family member, you can say, if you could put your dad in a chair right next to us, and if your dad could see this and understand the situation, what would he say? That tends to take a burden off the shoulders of the family and allows them to think more clearly. Remember, you're going to figure out the goals and values. If there's only one thing you take away from this 20-minute talk, that's it. You've got to find out what's important to the patient before you can start talking about artificial respiration and artificial resuscitation, which includes CPR and all the other things we do. So one of the number 5 is you want to align with the patient and the family. You want to let them know you've heard what they said. From what you've told me, it sounds like your dad really values being home with everyone and being really independent. And this shows that you've explicitly listened to the patient and their family. Mr. Jones, we want your mom to recover too. And in the case where the family says, Dr. Manfredi, God's going to step in, we're going to get a miracle. You know how I respond? I say, I'm wishing for a miracle, just like you. Can you tell me more about what a miracle looks like for you? So when you affirm the values, the patient and the family know that you've actually listened to them. So you're going to recommend a plan. You're going to ask first, is it okay if I recommend a plan? And you're going to present the positive part of the plan first, then talk about what you might withhold. So, Jane, it sounds like you would want to allow a natural death and would not want artificial life support. So we're going to do everything we can to provide comfort and give you the medical care you need. What we won't do is CPR or put you on a ventilator. Did I get that right, Jane? And if you can't get to a plan in the few minutes that you have in the emergency department, then suggest a time-limited trial of artificial life support. The important thing is remember to start the conversation. Don't wait. If you can plant the seed in the family or the patient's head, this sets up the next team upstairs in the ICU or with the palliative team so that the discussion can continue. So what's the ED method for goals of care? Remember, they've come in, they're in crisis. You're going to reframe their situation and say to them, you're in a different place now. Give the headline of what you found out in your workup. And then usually it's bad news. So you're going to expect emotion and you're going to respond empathetically. You're going to determine what the patient's values and goals are. Once that emotional temperature has been brought down, you're going to ask them, what really gives you meaning and purpose in your life? Because if I know that, we can move forward and I can help you make the decisions you need to make in the future. Once you know it's important to them, just sort of repeat it back to the patient and the family. Mirror back what you've heard, and then ask if you can recommend a plan. So, points to remember forever. Goals of care discussions are for all serious illness. That's what we see in the ED, not just end of life or resuscitations. Deliver that news with a headline, not a novel. Make it succinct and meaningful. Use empathetic statements to respond to emotion. And a question that seems cognitive may be an emotional response. Are you sure, doctor? I can't imagine how difficult this must be for you to hear. And always, always, always find out what's most important to a patient before you talk about the plan at all, before you ever utter the words artificial life support. And use that word, artificial life support, or allow natural death. Don't use those other words, CPR, intubation, and provide a recommendation to the patient and the family. Don't offer them a resuscitation sandwich because Remember, you are the physician. Thank you so much for your attention today. I really appreciate that.